I want to thank you for the nice invitation to speak a little bit about DDH and sonography. And I will start with questions. Is screening still useful, or do we need to adapt our strategies? This is the first. And now, what is the reality? In 2010, the World Health Organization had a conference in Berlin during the Bone and Joint Decade. And what was one of the statements? In the Western countries, 10 till 12% from the 50 years old patients needs a total hip replacement only because old DDH problems. That says we have a lot of problems in rather young people. And we did not really believe. And we did an own study, and it was also very interesting. We checked patients, why patients which had been 30 years old need a total hip replacement in our country. And the outcome was more or less terrible. In 51%, the problem was a DDH problem before. So, I'm not discussing the costs of the total hip replacements and rehabilitation and so on. These are our problems. What is the aim of ultrasound? On the one hand side, we want to make a diagnosis about the DDH, the luxation for itself, but this was only in the very beginning. 30 years ago, we had been very happy to see a dislocated head. Yeah, a so-called congenital dislocation. The standard we have today in our country is that we also want to detect early dysplastic acetabulum to avoid late correction like triple osteotomies or something else. We want to decrease the operations, the pre-osteoarthritis, and if possible, to reduce the number of total hip arthroplastic in rather young patients. Now, if we are talking what we should do we do a general screening or a selective screening, which is discussed now in the literature, most of all in the English-speaking literature? I will start with 10 questions. One of the questions is to you, you are all orthopedic surgeons. I ask you the following. What is the Ortolani sign, the Barlow sign, the triglic phenomenon, the glissement according to Pedrin, the phenomenon of the loosened capsule, and the so-called Dennis click? What sign in what age is normal? When one sign changed to the other sign? And how the hip joint looks inside from the pathological point of view when you feel one of the signs. If you can do it, I pay you immediately here $100. Yeah? I ask in Riccioli, one of the senior assistants where Ortolani had worked, here is the ballpoint pen. Here is the whiteboard. Show me how the hip joint looks inside when you feel the typical Ortolani sign. It was not possible. Yeah, I was the winner. So be careful if you talk with me about one of these clinical signs. Yeah, be very, very careful. Normally, I'm the winner. I ask you, what is the risk? Is it the family history, the scoliosis, the breech presentation, the female, the premature, clubfoot, torticollis, overweight twins, or is the risk the medical doctor? Yeah, what is the risk? Everybody is talking about thin folds and so on, but now I want to know what is really the background. Yeah, what is the evidence? What we do need today is a family history. The breech presentation, female, and the overweight, and all the others you can forget. So, hip sonography is discussed for screening. Leads it to overdiagnosis, overtreatment, have we missed cases in the American literature? Oh, hip sonography is not safe, it is not possible to detect even dislocated hip joints by sonography. We have to discuss it. What is about instability? What are the costs? Who should do it? and when we should do it. A lot of questions. So I try to give you the answer or some comments. We start with the last point. Who and when. Who should do it? It is not possible to do hip sonography without a special training. It is impossible to learn it in bedside teaching. It is like a new operation. It is strictly standardized, without influence of your experience and skill today, if you do it in the correct technique. And we do now courses worldwide, but you see, you cannot learn if you are sleeping. It is impossible. I ask you the following, a very question and short question, and you can vote. We did a course in Great Britain. Basic course, 2.5 days basic course for hip sonography. The delegates had been one group, listen, medical doctors, orthopedic surgeons, pediatricians, and radiologists. First group. Second group, sonographers, that means technicians. The next group had been nurses, and the last group had been mothers, because we did it in the maternity ward, and for training, the mothers brought their newborns for exercising the delegates. So again, medical doctors, sonographers, nurses, and mothers. And we vote in this sequence. Up your hands. What do you think? Who did hip sonography after 2.5 days in the best way? And if you think this group is it, up your hands. You got the question? Vote. Medical doctors, up your hands. We are the best. I am a professor. I never have an infection. I never have a luxation in the total hip prosthesis. Never. I'm the best. Medical doctors, again. Technicians. Nurses. Mothers. No, but nearby. In the best way, hip sonography is done by the technicians. Then by the nurses, and medical doctors and mothers have had the same level. Do you know why? Because it was also, and it is worldwide the same. Hip sonography in the technique we use in Central Europe is strictly standardized. You have to do it according a checklist, like starting an aeroplane. Checklist. Tack, 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 tack. And if you say to a technician, do it in this way, or to mothers don't know what is it. You have only to say, you have to make in this way, and you have to see this white spot. Then they say, yes, sir. If you say to a medical doctor, do it in this way, he say, I do it in a slightly modification. I have a lot of experience. And then the outcome, you see, the outcome is here. They are frustrated and say, I do it in another way. It is not working. We did all the mistakes. When we should do it, this is the so-called maturation curve that shows how the ossification of the hip joint goes ahead. 6th week, 12th week. What does it say? If you have your diagnosis very early, then you have a huge potential of growing in that cerebellum and a long time. This says I have a small plant, a small tree, with an enormous potential of growing. Then you can flex all the branches and the trunk and nothing will happen. But if you have an old tree, maybe 10 weeks, then a rather poor potential of growing and a short time. This is the old tree. If you want to flex an old tree, you have to cut it. It is not possible to make a flexion of the branches. So in conclusion, we must do our diagnosis and start with our therapy within the first 6 weeks alive. We have to discuss whether it is in the first day and so on. That's politics. But this is the best time. This is the time window where we must have the diagnosis, and if necessary, we start with our treatment. Does hip sonography leads to overdiagnosis? If you don't know the problems, you will have a lot of overdiagnosis. Maybe. If you have a tilted probe, that means that your probe is only a little bit oblique, it leads to overdiagnosis. Yeah, because of the reflections and the bowing and deflections of the ultrasound beam between muscle and hyaline cartilage femoral head, there is you will get a wrong diagnosis. For example, look here. Look to this acetabulum, to this angle, 65. Then if you tilt your probe, it goes down to 48 degrees, 20 degrees tilting, then you have a wrong diagnosis. And of course, an overdiagnosis. Yeah? And then you are wondering that without any treatment, the hip joint becomes healthy. It never had been a pathological one. Yeah? Look to some papers, English literature, unfortunately, I have to say, with curved areas, with sector scans. You can forget it. You will have a lot of problem of your overdiagnosis. For example, even you have never seen a sonogram. I want to show it. This is the femoral head. This is the bony roof. This is the cartilage roof. This is the labrum. Look to the proportion. This is the the bony acetabulum roof. And if you tilt the probe so that the ultrasound comes in this direction, look what happens. Yeah, it is decreasing and it looks subluxed suddenly. Of course, it is an overdiagnosis for nothing, and you must know these problems. What we do is we make an analysis of the hyaline cartilage deformation and the bony socket, and then we make an analysis of this anatomy according to the age. What does it say? Another bad joke. Yeah? My liver here, according Chardonnay, yeah, gin, vodka, is according to my age. Okay, but if the young lady here, you have the same liver here, like I, oh my dear, you have to be careful. So we have to take into account how old is the baby. For example, if you see this one here, femoral head, bony roof, hyaline cartilage, labrum, it looks like a little bit dysplastic. But if this is a 2 weeks old baby, it is completely according to the age. We call it a so-called immature hip joint. Needs no treatment, has a spontaneous ossification. But if it is 8 months old, it is a dysplastic one and needs immediately treatment. And if you don't separate what is a normal according to the age, if you have only a classification, it is normal, dysplastic, dislocatable, and so on. You go back 30 years back to our history, and you can forget hip sonography. We have to take into account how old is the baby, and you see it in this scale. Missed cases, of course. If you have no classification system, it goes down the river. For example, this is, unfortunately, an example from Switzerland they sent me. This is a newborn here. This is the femoral head, this is the bony roof, the cartilage, the labrum. It is quite clear the femoral head is inside the acetabulum. But it is a so-called type 2C range. That means it is inside, but has no chance for spontaneous recovering. If you do nothing, step by step the head will dislocate. You have to treat it immediately, then you can avoid the developmental of dislocation. This was the reason that the term was changed from congenital to developmental. What happens? You are not, if you do nothing here, you are not wondering that 9 months later the hip joint looks so. And if you have no technique to classify it, then of course you will say hip sonography is not safe. It is not possible to detect a dislocated hip joint. It was not dislocated in the first moment. It was developing a dislocation. And the aim of hip sonography is to detect the situation before they are dislocating. Another example, what about instability? If you move the femoral head, always you see, oh, the hyaline cartilage roof and the labrum goes up, and you make a stress, a so-called dynamic examination. Under stress, even in completely normal hip joint, it is possible to press the femoral head outside a little bit. Now it is the question. You feel and you see the head is movable inside, but you have to clarify and to make it clear whether this is, according to the age, completely harmless or it needs immediately treatment. So we have to separate the movement of the head in the acetabulum in two parts. In harmless movements, we need elastic whipping, and in real pathological one, we need that we say it is real instability. And this I want to explain here. If something is, if the femoral head is moving inside, we have to separate. If this moving may be, for example, because of a loosened joint capsule, or it is moving because the bony socket is poor and needs immediately treatment. For example, a newborn. Yeah, a newborn hip joint. Even you see it here, even you have no experience in hip sonography. This is the femoral head, this is the bony roof, hyaline cartilage, labrum. Yeah, so without any stress. And now you push. What happens? Compare the sonograms. Femoral head is here, and because you had made a stress, a so-called dynamic examination, better is to say stress test, you see, oh, the labrum goes up and the femoral head goes slightly outside. Now you have to make the decision, is this dangerous, yes or not? It is harmless, no treatment, or you have to treat immediately. If you have not a system to quantify and to measure it, you look outside and say, oh, maybe it looks pretty nice, or not. And then you will have a lot of disappointed situations later. In this case, it needs immediately treatment because the bony roof is very poor. On the other hand, if you look here, another example, you make also a stress, it goes only up a little bit, but the bony roof is good. This is completely harmless, needs no treatment. And now I come to some results and our experience. We have in Austria, Germany, in Switzerland, and also in the Czech Republic a general screening that says all the babies will be checked sonographically within this time window I explained before. If we talk about the incidence of dysplastic hip joints, we have to be careful worldwide because the incidence is in the countries highly different. Even only in Middle Europe, you see 0.9 to 7.7%. So, if you want to look what is the advantage of hip sonography, you have to make it locally and not worldwide. This is the first mistake which is done in the international literature. Some examples. Germany. We have the statistic from the Germans from 1979 up to 96. And under the influence of increasing hip sonography, you see what happens with the hospitalization because congenital dislocation. It dropped down dramatically. Next example. Yeah. What's about the late cases of DDH? If you do only a clinical screening, you have this rate of late cases. Risk screening, top down, and if you do a general ultrasound screening, the late cases are very, very small. What's about the costs? And these are in British pounds from John Gleck from the Midlands. what are the costs for a dislocation when you detect the dislocation only clinically? The costs are 31,000 pounds because the babies are old, needs a lot of hospitalization, operations, and so on. This is risk, and these are the treatment costs if you detect a DDH case by sonography with a screening. And I think between 31 and 1,000 is slightly different. It is different. Let's go ahead for example from Poland. This is from the Department of Wrocław. I thank my Polish colleagues, they sent it me. Yeah. So from 1980 to 2004 we have this statistic. These are the operations in this department. Look what happens. Then in 82, very early, they started step by step with sonography. And the curve goes down of the operation more or less symmetric. Yeah, from 3,500 to less than 500 a year. And I think this is a big advantage for the government, but also, of course, for the patients. Germany. We have the statistic of the screening from 96 to 2001. The coverage range had been, you see it here. And what happens? They reduced within 5 years the operations from 1 to 1,000 to 1 to 4,000 because of the general screening. Austria. We compared the following. In 1991, in Austria, a general screening was introduced, and 1 year later, that means in 92, we wanted to see what happened and compare the results with the results from 81. Yeah, this is the statistic from the Ministry from Common Health, the official statistic all over Austria. It's not my statistic, it's from the government, the statistic. And what is the outcome? Within 1 year, we reduced the treatment rate 50%. We reduced it. Do you know why? Because in the time before sonography, we did the treatment according our clinical examinations. And then very often we, doctors, said, safety first, we use a splint or a harness, nothing can happen. So we reduced it because we started with the treatment according sonography and not our personal feeling and experience. The open reductions dropped down, the osteotomies and the costs dropped down 1/3. Now we have another statistic from the government. From 91 to 2004, in this statistic are 70 to 80,000 babies a year. In 1 year. And from 91 to more than 1 million babies are here inside. Yeah, nobody in the world has such a statistic. These are the newborns. What are the results? The conservative treatment dropped down step by step under the influence of hip sonography. And now we have a peak here. And we had been very astonished. And in the first moment we thought hip sonography leads to overdiagnosis. And then we made an analysis what cases it had been. And the outcome was, it was the war in Yugoslavia. We got a lot of refugees, rather old babies, not screened babies. And this was the reason that we had this peak of treatment here. Open reductions. We reduced the open reduction step by step up to this day to 0.13. This is the lowest rate of open reductions worldwide we have now in Austria. Acetabulum-plastic, Salter osteotomy, Degas osteotomies. You see what happened under the influence of hip sonography from 91 to 2004. Step by step, the operations more or less disappeared. And now we have this next problem. We have to less cases for operations to train our young doctors. Can you imagine? My clinic is specialized in orthopedics for children, and we have to less cases to train our doctors in salt osteotomy. I have young professors that never had seen a salt osteotomy. Yeah, when we don't get some babies from other countries, we have no chance that we learn these osteotomies now. What are the costs? The costs in Austria, the treatment costs drop down dramatically. We must not discuss it. This is an example from Mongolia. It is very important that the compliance of the parents is trained. If the babies are packed together like these dolls here, you will damage immature hip joints. It is unbelievable. In Mongolia, in Ulaanbaatar, they started with a general hip screening. Swiss orthopedic surgeons and pediatricians 5 years ago had established a training program in Ulaanbaatar. They sent them the ultrasound machines, they trained all the neonatologists, and each evening they sent the sonograms. They did all day long by email to Switzerland. A group of doctors check the quality and send them back. They have an unbelievable high standard. Yeah, because they have of this, because of this squabbling, they have a lot of problems with hip dislocations. If we talk about general screening, and now I come to the end, don't worry about. It is not in our hands whether we say screening yes or not. I never stressed my colleagues for screening. The mothers make the stress because we checked only so-called risk babies 25 years ago. And what happened? Suddenly the mothers came and said, hips, because mothers, they know hip sonography from they know sonography because of their pregnancy. And they say, why this baby is checked and not my baby? What does it cost? I also want that you check my baby. And the mothers stressed our government and social system. We want also to have this service. Please, we want to have a general test. And so this is the reason that also in other countries, more or less, it comes up worldwide. It is unbelievable. I can tell you a story from India, maybe in the discussion. It was really, for me, it was also very interesting and astonishing what the Indian colleague told me. That is my final statement. To screen or not to screen, this is not the question. It's politics. Yeah, that is it. But if you do it, then do it in the correct technique. You must have a training. It is out of experience and skill hands. It is standardized like a checklist according to the pilots, and the other techniques is forget. We did all the mistakes before you. There is no need that you do the mistakes again. And this is also a slogan, better hip sonography today than a limb tomorrow. And this is the best position in utero you can do for your babies. The gentleman is quite happy in this position. Thank you for your attention.
So thank you for your beautiful lecture, and now it's time for questions to Professor Graf.
If you were presented with a static picture of an ultrasound, would you be able to tell whether the probe was placed correctly or incorrectly?
Yeah. Your question is very important. We have this standard that I can tell you, if you show me the sonogram, in what position you had the probe on the sonogram. In this position, so or so. That's classified, standardized. This is the so-called tilting mistakes you can do. Yeah, show me your sonogram and they can tell you how you had put the probe on the sonogram. This is the standard we have today.